Hello everyone, my name is Noura. I am a clinical pharmacist resident in internal medicine department at An-Noor Hospital. And today, during the round, I had a question about peritonitis, and I thought it would be helpful if I shared what I found with you guys. So 80 is 67 years old male came to ER complaining of nausea, vomiting, and abdominal tenderness with high-grade fever. On physical examination, the doctor noticed abdominal tenderness, distension, and faint bowel sound that cease over time. Finally, the lab result came and it shows leukocytosis more than 15,000 cells per millimeter cubic, elevated hematocrit, and elevated blood urine nitrogen, and blood pH was almost show early sign of alkalosis. So 80 admitted as a case of peritonitis and culture was sent. Before we go further, some of you may never heard about peritonitis. So what is peritonitis? So basically, peritonitis is an inflammation of the peritoneum as a result of infectious or chemical inflammation within the peritoneal cavity. And peritonitis can be classified as primary, secondary, or tertiary peritonitis. Let's start with primary peritonitis. It involves the development of infection in the peritoneal cavity in the absence of intra-abdominal pathology, and it's also known as spontaneous bacterial peritonitis (SBP). And it's most frequently identified in adults with cirrhosis and ascites. Next is the secondary peritonitis, and it classically results from the contamination of the peritoneum with a gastrointestinal microorganism as a result of the loss of the mucosal barrier integrity. The last one is tertiary peritonitis, and it's clinically peritonitis along with sign of sepsis and multi-organ dysfunction persisting after the treatment of secondary peritonitis. It's interesting to mention that subcutaneous bacterial peritonitis occurs in both children and adults. Subcutaneous bacterial peritonitis is a well-known complication of cirrhosis. 70% of patients with cirrhosis and subcutaneous bacterial peritonitis are childbirth class C. The development of subcutaneous bacterial peritonitis is associated with poor long-term prognosis. In patients with ascites, the prevalence may be as high as 18%, although the etiology and incidence of hepatic failure differ between children and adults. In those individuals with ascites, the incidence of subcutaneous bacterial peritonitis is roughly equal. Well, it's interesting to mention that there's two peak ages for subcutaneous bacterial peritonitis in children, one in the neonatal period and the other at age of 5 years. So since I talked about different classes of peritonitis, I should mention that the causes is different from class to another. The causes of primary bacterial peritonitis could be either due to peritoneal dialysis, cirrhosis, ascites, or nephrotic syndrome. And here what I found about the causes of secondary bacterial peritonitis. It could be due to either miscellaneous causes such as diverticulitis, appendicitis, inflammatory bowel disease, or necrotizing pancreatitis, or it could be due to neoplasm, which will cause intestinal obstruction and decrease perforation, or it could be due to mechanical GI problem as in a cause of small bowel obstruction such as hernia. Vascular causes involve venous or arterial occlusion or ischemia without occlusion. Trauma could be causes for secondary bacterial peritonitis, especially abdominal trauma with rupture of intestine, also penetrating abdominal trauma. Heterogenic intestinal perforation such as endoscopy could result in secondary bacterial peritonitis. Surgery can result in secondary bacterial peritonitis in different ways, either by intraoperative events or peritoneal contamination during abdominal operation or leakage from gastrointestinal anastomosis. Well, you need to remember that there is certain risk factors for peritonitis. So you need to keep an eye on patients with peritoneal dialysis, medical conditions such as appendicitis, stomach ulcer, cirrhosis, and so on, and history of peritonitis. It's important to mention that the causative organism of each type of peritonitis is different from the other. For primary bacterial peritonitis, the causative organism is often caused by a single organism. In children, the pathogen is usually group A Streptococcus or Streptococcus pneumoniae or E. coli or Bacteroid species. In patients with peritonitis associated with cirrhotic ascites, E. coli is the most common organism, while in patients with peritoneal dialysis, skin organism is the most common organism, such as Staphylococcus epidermidis, Staph aureus, and diphtheroid. While on the other hand, the causative organism of secondary peritonitis are often polymicrobial. The combinations of aerobic and anaerobic organisms appear to greatly increase pathogenicity. Aerobic enteric bacteria and anaerobic bacteria are both pathogen in the intra-abdominal infection. Aerobic bacteria, especially E. coli, appear responsible for the early mortality from peritonitis, where anaerobic bacteria are the major pathogen in abscesses, with bacteroids predominating. And here the percentage of pathogens isolated from patients with secondary peritonitis. As you can see, E. coli is predominating as gram-negative bacteria, while in gram-positive, Streptococcus is predominating. And it's interesting to mention that peritonitis could be due to fungal infection as well. To start the empirical treatment, doctors should decide whether it's primary peritonitis or secondary peritonitis. And another way to differentiate between those two is the sign and symptoms. For primary peritonitis, the patients may complain of nausea, vomiting, with sometimes diarrhea and abdominal tenderness. Temperature may be only mildly elevated or not elevated at all in patients undergoing peritoneal dialysis, and the bowel sounds are usually hypoactive. And a cloudy dialysate fluid may be found with the peritoneal dialysis. Another way to differentiate between these two is the lab result. For primary peritonitis, patients' white blood cell counts may be only mildly elevated. Ascitic fluid usually contains more than 300 leukocytes per millimeter cubic. In 60 to 80% of patients with cirrhotic ascites, the gram stain is negative. Other tests include the culture of peritoneal dialysate or the ascitic fluid, and it should be positive. On the other hand, the signs and symptoms of secondary peritonitis involve generalized abdominal pain, tachypnea and tachycardia, nausea and vomiting. The temperature may be normal at the beginning, then start to increase to 37.7 to 38.8 celsius within the first few hours, and may continue to rise for the next several hours. Hypertension and shock if volume is not restored. Decreased urine output due to dehydration. Physical examination. Patients with secondary peritonitis will show voluntary abdominal grading changing to involuntary grading, abdominal tenderness and distension, and faint bowel sounds that cease over time. Now let's talk about the laboratory test for secondary peritonitis. Unlike the primary peritonitis, in secondary peritonitis, patients' white blood cell is ranging from 15,000 to 20,000 cell per millimeter cubic. The result will show elevation in the hematocrit and blood urea nitrogen as a result of dehydration. Also, the patient will progress from early alkalosis because of hyperventilation and vomiting to acidosis and lactic acidemia. The other diagnostic tests involve abdominal radiographs, ultrasound, CT scan, or MRI. Finally, the treatment. But before we start talking about the pharmacological treatment, we need to discuss the non-pharmacological treatment. For secondary peritonitis, it can be treated surgically, and this is called source control, which refers to the physical measures undertaken to eradicate the infection. Also, aggressive fluid repletion and management are required for the purpose of achieving or maintaining proper intravascular volume to ensure adequate cardiac output, tissue perfusion, and correction of acidosis. In the first hour of the treatment, a large volume of IV solution, mainly lactated ringers, may be needed to restore the intravascular volume. This may follow by up to 1 liter per hour until fluid balance is restored within a few hours. In patients with significant blood loss, hematocrit of 25% or less, blood should be given. Always do not forget the internal or parenteral nutrition, which improve the immune function and wound healing and ensure recovery. For cirrhotic patients with suspected primary bacterial peritonitis, we should start cefotaxime as empirical treatment. If anaerobic bacteria were suspected, we should add clindamycin or metronidazole to the cefotaxime as empirical treatment. Other alternatives include aminoglycosides such as gentamicin with antipseudomonal penicillin such as piperacillin, tazobactam, or tazocin. For empirical treatment in patients with peritoneal dialysis and suspected primary bacterial peritonitis, we should start cefazolin with ceftazidime or cefabime. An aminoglycoside such as gentamicin could be used in the place of ceftazidime or cefabime with the cefazolin as empirical treatment. Imipenem calistatin or cefabime may be used alone as empirical treatment. For primary bacterial peritonitis caused by Staphylococcus, penicillinase-resistant penicillin or first-generation cephalosporins such as cefazolin can be used as monotherapy. Patients with peritonitis caused by MRSA should be treated with vancomycin. With vancomycin-resistant Staphylococcus aureus, linezolid is a drug of choice. For patients with Streptococcus or Enterococcus, ampicillin is drug of choice. And I found that an aminoglycoside such as gentamicin can be added for enterococcal peritonitis. And we should use linezolid for patients who are suffering from vancomycin-resistant enterococcus, which is not susceptible to ampicillin. For patients with aerobic gram-negative bacilli, ceftazidime or cefabime is the drug of choice. In patients with primary bacterial peritonitis caused by Pseudomonas aeruginosa, two agents with different mechanism of action, such as oral quinolones like ciprofloxacin, plus ceftazidime, cefabime, topramycin, or piperacillin should be used in such patients. Well, now let's talk about the secondary peritonitis treatments. So first of all, for patients with perforated peptic ulcer, we should use first-generation cephalosporins such as cefazolin, and we can possibly add aminoglycoside if patient's condition is poor, such as gentamicin. Well, what we can do if the patient was allergic to penicillin? Well, we can give aminoglycosides such as gentamicin with clindamycin or with metronidazole. Well, we just talked about the secondary bacterial peritonitis that's caused by perforated peptic ulcer. For other reasons, the other options include imipenem, calistatin, meropenem, or extended spectrum penicillin with beta-lactamase inhibitor such as piperacillin, tazobactam, or tazocin. Other options for secondary bacterial peritonitis include ciprofloxacin with metronidazole, azithromycin with clindamycin, or with metronidazole. Okay, we almost finished. I just want to summarize the main points that we discussed today. First of all, we said that peritonitis is an inflammation of the peritoneum as a result of infectious or chemical inflammation with the peritoneal cavity, and we said that there are two main classes of peritonitis: primary peritonitis and secondary peritonitis. And there is many differences between the primary and secondary peritonitis. For an example, the primary peritonitis is caused by single microorganism and mainly it's gram-negative, while the secondary peritonitis can be caused by polymicrobial and most of the time they are combination of aerobic and anaerobic pathogens. And we discussed the different signs and symptoms for each class. And just to remind you, patients with primary peritonitis will probably not have high-grade fever, unlike the patient with secondary peritonitis. Also, the white blood cell counts for patients with primary peritonitis will be normal or almost normal, while the patient with secondary peritonitis will suffer from leukocytosis. For further reading about the management and treatment of peritonitis, I think you should take a look on the guidelines of the Intra-Abdominal Infection by Infectious Disease Society of America, IDSA. I think you will find it helpful. Well, that's all I had to say about peritonitis. I hope it was useful for you guys. And thank you for listening. And remember, pharmacist is always the medication expert.